I'd like to begin this podcast by acknowledging the Turrbal and the Yugara people, who are the traditional custodians of the land on which we meet today to record this podcast. I also would like to pay my respects to their elders past, present, and emerging. Hello, Academy Associates. Thanks for choosing to listen to the Bodytrack Academy podcast, where our aim is to bring clinical research to real-life clinical practice. For further learning opportunities, why not access our educational webinars? To access, click on the link in the show notes. To keep up to date, join our Academy mailing list where you'll receive exclusive content, discounts on webinars, and more. Link to join us is also in the show notes.
Okay. Welcome back, listeners. Today we have Caitlin back joining us for part 2 of our sort of lower limb injuries. In part 1, we spoke about more tendinopathy related injuries and sort of making this a little bit more specific to runners. And that was off the back of a little bit of a incline and take up of running recently. A lot more run clubs going around. So today we're going to be talking about bone stress injuries. So welcome back, Caitlin.
Thanks for having me.
So start us off, I guess we just spoke before, bone stress injuries, new terminology or sort of new name for these types of injuries leading away from bone stress fractures.
So bone stress fractures are still a terminology that we use, but we consider it across a spectrum. So when we're talking about a bone stress injury, that's where the bone is generally unable to stand with repetitive loading, which means to a localized weakness and pain. So that's the variation of the stress reactions we will see across. When you actually get a break to the cortex, that's when you actually get your stress fractures or a bone fracture through there. So that's sort of where we're thinking, because depending on the nature of how someone presents for rehabilitation will depend on how you actually manage that injury going forwards.
Perfect. So leads me into my first questions. What is the most common bone stress injury you see in someone sort of starting to run or someone who's done a little bit of running?
So someone who is getting into running, I see a little bit of tibial stress fractures, and stress reactions are quite common. Also seeing metatarsal stress fractures as well and stress reactions. So they're probably the most common getting into runners. Those that have been running for quite a while, you tend to see a little bit of a different injury. So they're the ones that are more conscious that they might have more of a femoral stress fracture. But often with your runners that have been running for a little while, there's something else that's changed as well. So it's either a change in running volume, a change in their intensity of their running, or there's some other factors around hormones, diet, weight that are contributing from there.
Yeah. And as exercise physiologists, again, like we don't diagnose these things, but these are stuff that it's really important that we are able to sort of identify and refer on to where we need, because we do have a lot of people coming in that might want to start running or might present with an injury where they think it's something else. So can you give us a bit of an overview of how do these clients present? Are there any similarities between other conditions as well, or presentations that we should be aware of?
So it's really common. I guess the common one that I'm seeing a lot of people talk about are your femoral neck stress fractures. So they're the type of stress fractures that may suddenly present during a run with patients. So they've just been loading, and then there's a change that results in a pain provocation. And they're often the ones that are saying that they constantly feel tight across the front of the hip. So they're the ones that are saying, oh, I just need to stretch out my hip flexors. I just need to stretch out my hip flexors. So they're a very big one that I'm very aware of. And especially if they've got a background of running, I do a really big deep dive into what's your running, what's your volume, what's your intensity, what's changed, have you been unwell, to see if there's any risk factors that are niggling away.
And would that pain provocation during a run, would that be up and down, or would that be a consistent discomfort?
Be consistent discomfort. Yeah. So these, with your stress reactions, they don't warm up with it. So as compared to tendons, we know tendons, once you get them loading a little bit, start out a little bit stiff, niggly, and then they warm up. Your stress reactions and your stress fractures do not. So that's then the questions I'm asking is, okay, how long into your run do you feel it? And does it go away? is a really important one. Then when I'm thinking more around your tibial stress reactions and stress fractures, you're really thinking about the other muscles that are around the area. So have they got some underlying medial tibial stress syndrome going on? Are they actually loading more of the structures around? Do they have a periosteal inflammation? So have they got inflammation of the bone, which is one of the early signs of a stress reaction? Or have they just actually got a bit of a tib-ant overload because of their running biomechanics? So there's a couple of little factors that you've got to link into it to go, okay, what am I thinking from there? But there's a really nice bone stress algorithm that was published in 2016 that actually talks through some of the questions and the signs that you can ask of a patient to identify, okay, do I think this person actually has a bone stress reaction or a stress injury that warrants further imaging or investigation? And that's a little bit that I frame a lot of my questioning around. Now, it is quite common that we see a lot more stress reactions and fractures in women compared to men. That's just associated a little bit with our genetic makeup, with hormones, but that's all important factors that I'm considering when someone's coming into me with a new onset of pain or a pain that just keeps coming. They'll have a bit of rest, they'll get back into activities, pain comes back. A little bit of rest, come back, pain returns.
Yeah. Building on that, are there any sort of physical assessments that are a pretty sort of dead giveaway? Are we looking at sort of maybe loading the single leg or shifting the weight shift and stuff like that? Obviously, we need to be really mindful of those things. But I guess
question.
For me, it's more like, okay, if someone did come in with these niggles and we needed to make some decisions around modifying training, where would we go first?
So you would have a look at general double leg function and unloaded positions, because if you're getting any protective joint spasm or any protective restriction, that's kind of a little bit of an indication that something else is going on and we might need to get that checked out. So if you're seeing any of that, I would be referring on straight away. When it comes to more the single leg, it's just about, again, seeing how an individual's going. If they're okay with a double leg squat and you want to introduce a single leg squat to see how it goes, introduce that, see what their mechanics are like, see if they can control it. If they're getting any spikes in their pain or change in their pain and you're suspicious that it might be bone, refer on. So one of the tests that the literature talks about is the HOP test, but I rarely HOP my stress fractures unless I have explored everything else. So if you've got someone coming in, they're saying they've got a new pain with running, it happens every time they run, they've got a little bit of awareness with it with day-to-day activities, I would refer them on. I wouldn't even try to explore what's going on.
Yeah, and I was going to say like a single leg hop. Pretty high intensity, probably end of the range. And I guess like, looking at running mechanics, they're probably going to be able to absorb their load a lot better than simply just hopping straight up and down. I'm at tread lightly with that one.
But in saying that, though, there's a new body of literature that's coming out that's looking at a return to run paradigm and going, well, how can we actually look at someone's readiness to return to run? And they're actually saying that hopping is a better indicator of someone's readiness to return to run as compared to doing calf raises.
Yeah, interesting.
So we need to have an element of the endurance through there, but to actually see if someone is ready to run, we can have a little bit of a look at hopping. So it's sort of, I guess you've got to have a look at the bigger picture and going, I've got someone who is interested in starting running and we're seeing what their mechanics might be like under load, or do I have someone who's been running for a little while, they're getting these niggles and pains, I'm going to be really cautious about whether I actually run them or not.
Yeah, I think with that, probably like training age and experience would be a big one in how well someone can actually execute a single leg hop. Because if they haven't done much running, haven't done much exercise, like I'm sure a double leg hop would probably not be great in terms of mechanics and force production.
And you'll always start at the lower end and build it back up. But again, if you're suspicious that this might be a little bit stress reaction, stress fracture, don't hop them, refer them.
Excellent. And who are you referring to?
So when they come and see me and I've got an index of suspicion that there might be a stress fracture, I send them for imaging. So I send them straight for an MRI because an MRI is going to give me an indication of whether there's actually any periosteal edema. So is there any actually swelling and changes into a bone? Because an X-ray is only going to tell me if there is a break in the cortex of the bone. From there, depending on the individual. So I've got a young girl at the moment that I'm managing with bilateral stress reaction. She didn't go to a full stress fracture. She really wanted to get a really good time for the Bridge to Brisbane, increase her training, heaps of speed work, caught it early. So imaging, managed her, and she's back into full running without concerns. I've got another lady who's in her 50s that was a sudden onset of pain that we imaged, and she actually had a stress fracture, which we needed to moon boot. I sent her to a sports physician for management from there to go, okay, this is what I've identified. These are the contributing factors. Is there anything else we need to consider? So when we're dealing with someone that has what we talk about a low risk stress fracture, then we can generally manage them in clinic. If anyone's got a high risk stress fracture, then I refer them on to a sports physician just to make sure that there's nothing else that we need to be considering for management from there.
Excellent. We spoke a little bit about it earlier, and you said sort of females are more predisposed. If we had one of our clients or someone come in that wanted to start a running program, what are some of the big things that we need to ask in our subjective questioning that may predispose them to these conditions? So obviously a low training age, limited history of strength training and running or sports in the past. Are there any other factors that we need to be mindful?
Absolutely. So female sex, so understanding what their sex at birth is going to give you an understanding of that. With regards to that as well, asking about their menstruation. So I have regular menstruation, and I guess that leads then into the REDS and low energy availability. So REDS is the relative energy deficiency in sport, and the consensus guidelines from that. So we're really starting to understand that it's not just males that this low energy availability and relative energy deficiency in sport can affect. It can affect females on top of that as well. So it's really about understanding, okay, what's their hormones like. So especially if you've got someone that's a little bit older and perimenopausal or menopausal, we still don't have a big body of research around menopause and perimenopause and running related injuries. So it's about understanding they're going to have changes in their hormones. You might need to be a little bit slower with that on top of the tendon related changes with perimenopause and menopause. Asking about, do they have any history of prior stress fractures? Do they have any history of low iron or vitamin D deficiencies is really important as well. And how's that managed? And when was the last time that they were checked? Now, it doesn't mean they have to go off and have blood screening done then and there. It just means, okay, I need to be a little bit cautious with how I'm actually loading this individual from there. Any history of eating disorders, or if they're in a calorie restriction, is also an important one to understand. There is a little bit of evidence that talks about pes cavus, so having the changes with your foot positions. But again, it depends on the individual. If you're starting them nice and gently, it might not be as big, but it's just important to understand that, okay, do they actually have some good fitting shoes? They come into that. So that's, generally where I have a look at. And if I've got someone that's really keen to get into running, we'll often talk about, okay, here are some base strength things I'd like you to start with for 4 weeks, and then we can introduce running from there. So there was and I really like it as a baseline. So there was an article that was published last year, I believe, last year or the year before, that talks about return to run postpartum. I really like it because they've got some really clear measurables in there that they encourage women postpartum to be able to achieve before they start a running program. So I take that and run with it a little bit and go, okay, how can I target that to the individual that's in front of me? So that's, if you're looking at a way to get someone started and you're asking the history, and there's not too many risk factors through there, look at how their background strength, how you can start introducing some of that, then introducing some running.
Excellent. Moving on, so we've got the diagnosis, we've got the individual, we've screened across them. In those earlier phases, what sort of our rest times and our deload periods look like? They're very variable, and I'm sure they come on a lot of other factors for like, what are they doing for work and how much can they actually deload during the day, compared to our bone stress injury and bone stress fracture. What are the big differences?
So with a fracture, you're treating it like a fracture.
Yep.
So they're generally completely deloaded. depending on where the fracture is. So if they're high risk or low risk, we'll manage them a little bit differently. Your stress reactions are symptom dependent with it. So it might be going, again, with the young girl that I was seeing, I got her to stop running. I got her to stop walking outside of what she needed to do for her work. Managed to reduce her symptoms in 2 weeks. And then we gradually introduced her activities of daily living, introduced some more strengthening, then introduced running. With the other lady who had the full stress fracture through her tibia, she was in a moon boot, non-weight bearing for 6 weeks, and then she was gradual return to weight bearing in the moon boot for another couple of weeks. And then we got her out of the moon boot and started a very gradual walking program and then building her up from there. But again, if someone's quite high risk, so I have been dealing with a high risk femoral shaft fracture. She was in a wheelchair for 3 months.
Yeah, wow.
So it really, there's many different factors that you've got to consider with regards to management of them. So as much as I'd love to say, yep, full fracture 6 weeks, it depends on where it is in the individual as well. So you'll be guided if someone's got a fracture or a stress reaction by the physio or GP or specialist who's managing them.
Excellent. And in terms of, for I guess your runners, maintaining some sort of activity, exercise.
Mm-hmm.
Hello again. Thanks for taking the time to listen to our podcast. Another shout out to a sponsor that we have, the Barbell Jack, where you can master your lifts to save time, energy, and lift like a pro. The Barbell Jack isn't just any gym gadget though. It's your new best mate, designed to ensure a safe posture when changing weight plates. This is a must-have in your clinic. Embrace the power of professional lifting techniques and hit your personal records with ease. Use the code BODYTRACK to receive 10% off your order. Now back to the podcast.
Are you looking to continue to strengthening the non-affected side in positions that are comfortable, doing upper body strength? Would you be looking at the pool? What sort of other factors go into maintaining some level of fitness?
Yeah, I'd look at the pool. I'd look at rower with their foot on a skateboard. That way they're not putting too much load through there. If they're in a pool, we're talking lower limb. I'll generally not get them kicking. Again, depends on where the fracture is. Upper body, if they can be seated and they're not trying to grab the weights themselves, so generally machine-based upper body exercises. And it really depends on the individual as well and what's their capacity to be able to drive to a gym.
Yep.
What have they got set up at home? What are they able to do from that aspect of it? So always looking at ways to maintain control and maintain strength. Sometimes if I've just got an isolated lower leg around the metatarsals, I'll get them doing open-chained hamstrings, quads, adductors, because I know that's not going to do too much loading through that area. When it comes to tibial related stress reactions or fractures, that's a little bit of a different management because I don't want to load too much through the tibia.
Excellent. Coming towards the end of that rest period and looking to move back into some loading, is there a need to rescan these injuries or do they become dependent on presentation?
Depends. High risk, rescan. Low risk, managed based on symptoms unless they're having problems with it. And I guess the important thing that we know the literature keeps telling us and we know about bones is as much as you've had the time to deload, you're now symptom free. If there is a fracture, the fracture is no longer identifiable on imaging. That bone is still weak. And that's the big thing that people need to be educated on, going, you're not in pain. Your imaging shows that you don't have a fracture, but that bone is still weak and we need to build it back up to tolerate the loading from there. So that's then when we really educate, going, okay, we're going to start introducing things. It's going to be symptom based, but what's really important is even though you feel good, we are going to stick on this pathway so that we can improve your bone tolerance to loading so that we're not getting you into another overloading pattern.
Yeah, excellent. I think another thing to note off the back of that is like muscle atrophy in that time, especially if like your client who's been in a wheelchair, there's going to be a lot of atrophy in terms of the hip and the leg and the lower limb and essentially educating that client that, you know, the muscles will be supporting the bones as well.
I think another important thing onto that, and we see it, again, what's a lot of information that's coming out about osteoporosis is going for management of bone loading. We know loading the muscles actually improves bone capacity more than an impact-based activity does. So again, being able to educate the patients going, you're still going to really improve your bone health with the strengthening work that we're doing. We're just going to be cautious of when we increase that impact-related activities.
Yeah, excellent. Moving on to return to exercise and return to run. I know we're sort of talking leg or lower limb, which is, there's probably a lot of different protocols. Can you give us a general overview of how you would approach a return to load?
So from a return to load perspective, if they are pain-free with activities of daily living and they're able to do their job, then we introduce a graduated loading program. So identify what they have normally been doing previously, especially if they have a big history of running or strength training, and generally get them back at about 60% of what they were previously doing and build that over a month period. If there's someone that hasn't had a lot of experience in the gym or haven't done any strength training, then I simply start them with body weight exercises around what their capacity is for loading. And there might be some things I don't get them doing. So if they're not confident doing a single leg calf raise, I'm not going to get them doing a single leg calf raise. I'm going to introduce different other ways that we can load through that area. And then it's just about gauging how they're feeling week to week. What are their symptoms like? Do they have any night pain? Are they getting any symptoms? What's their DOMS like as well? So what's actually happening from a muscular perspective when we're increasing this loading? And then if they're tolerating that over a 4 to 6 week period, introduce a little bit of a light return to run from there.
Excellent. I guess you sort of use that general 60% of what they'd previously done. In terms of a return to run post bone stress injury, do you have any sort of formulas or things that you like to use based off their previous load or what they've done in the past?
Not specifically. So if I'm getting someone who's getting back into running, I significantly on the side of caution, and I'll generally give them a graduating running program that will be, okay, we're going to do a really nice warm up. I just want you to do a nice 1 minute run, have a walk, see how it feels. Normally the walk's 2 to 3 minutes. Do that again, do that for X number of cycles. They might do that twice in the week, monitoring for how they feel at the end, monitoring for how they feel the next day as well. And if that's feeling okay, then we can step it up gradually week by week from there. If they've got a big history with running and there's been a big spike in load that's resulting in a stress reaction, I drop them back a fair bit from their previous running load, but I don't necessarily get them starting back with that 1 minute. We'll go, okay, what is your normal start state for your loading after you've had a breakaway? And that's then when we'll build them up from there. But being very, very educational about symptoms, terrain, speed.
Yeah, excellent. No, I think they're good points. And there's not too much sort of, or you can probably correct me on this, but going through mine, not too much research, and especially in an EP's world, there's always a bit of apprehension around prescription of return to run protocols and loads, and we need to take in a lot of factors of the history, the injury, the strength and stuff like that. Are there any particular sort of like ratios or formulas you like to use in terms of like a walk, run, return, or does that number come off your clinical judgment?
Clinical judgment. If I've got someone who doesn't have a history of running and is getting into running, I do no more than 10% per week increase in loading, and making sure that they're having their regular deloading cycles as well. So that'll generally do a 3-week load and then a week deload. If I've got someone that's a more experienced runner and they've done a lot of like ultra endurance style running, so they've got a high volume during the week, then I'm more comfortable progressing them by 20% per week, and they might have a little bit of when they have their deload, they might have more of their deload at week 5 or 6 compared to week 4. But again, depends on the cycle that they were doing, how they've got their stress reaction or stress fracture, what's been the trigger. Has it literally been they did a big event that they hadn't properly trained for, or had they introduced a new terrain that was resulting in a stress change?
Excellent. And sort of looping back to exercise prescription, in terms of progression through a graded exercise program, would you be going based off symptoms in how you would want to progress? So your prescription, if they got through maybe 1 to 2 weeks of what you'd prescribed for them, it was not too challenging. The effort levels, say like your 5 or your 6, would you be looking for a quicker increase week by week, or would you be looking for a steady program and then phasing in the next?
Again, I think it depends on the individual and their background with the type of exercises I'm getting them to doing, especially if I'm looking at biomechanics and trying to do a slight biomechanical change as well, or kinematic change. I would be pretty comfortable progressing them within their tolerance if they've got a history of strength training, going, okay, you've really handled the 60% load, you're feeling comfortable with it, let's up it to 70% in 2 weeks and see how you're going. If that's going well, let's up it to 80%. But what I might also be doing is changing the exercises that they're doing at the gym. So really focused on some specific movement patterns when they're first getting into the gym, and then going, all right, let's introduce more a step up, let's introduce a lunge, let's introduce something a little bit different to see how you're tolerating that change in load.
Excellent. No, that sounds good. Beautiful. I think that's most of my questions I had for you. Did you have any questions for me?
How often do you think you would see stress reactions or stress fractures in clinic before they see other health professionals?
It's a good question. It's a little bit, I think where we mostly see them is with clients who are coming to us consistently, and then probably have that stress reaction. So usually I would say more on the recreational runner side, not so much on the athlete side, because they might have someone else, sort of their coach or managing their load. It is pretty rare that we would have someone come in for the stress reaction, but that's sort of why I alluded to those questions earlier in, okay, what are some key identifiers that if we do have someone that comes through the door and they sort of might have a history of a few other things around the hip and say, oh, you know, I've had this glute problem, something that we can address, knowing, okay, what are the red flags? But it's not very consistent. Usually we would see someone off the back end. So, for my example, I had a young male who was playing cricket, had a stress fracture in his lower back, pretty common fast bowler, the classic. Yeah. And then he was sort of out of the clinic for most of his return until he was cleared to return
and I
back
think
to activity. So
that's probably a big one that probably deserves a whole nother podcast on management of lumbar stress injuries in an adolescent population. So we might hold that one, because that's a really good one to talk through as well.
Yeah. Excellent. All right. Lovely. Thank you, Caitlin.
Thanks for listening. We hope you enjoyed this podcast. So remember to share, like, or follow to keep updated with all our podcasts and educational resources.